Welcome, everyone, and thank you for joining us today for the MyHPCO Bereavement Professional Community Chat, Prolonged Grief Disorder, Evidence-Based Practice, and Implications for Hospice. And now I'd like to introduce the presenter for today, Reverend Dr. Donald B. Stouder, Bereavement and Volunteer Manager at Reliance Hospice in Palm Desert, California, and the MyHPCO Bereavement Professional Steering Committee. Welcome, everyone.
Well, thanks, Don, for that lovely introduction and instructions. And hi, everybody from sunny Palm Springs. My name is Don Stouder. I work here at Reliance Hospice in Palm Desert, California, which is part of the Palm Springs metropolitan area, for lack of a better way to put that. And we've just entered our 100-degree day season just about a week or so ago. So here we go. It'll be 100 degrees now until about the middle of October. I also want to welcome the other two folks in our bereavement steering committee that are with us today, Karen Mons and Joel Osterhaus. You'll have the opportunity to hear from them, and hopefully they'll introduce themselves when they get the opportunity to talk. And I see we have about 105 folks with us so far. So obviously we want you to chat it up in the chat box. Tell us where you are and what the temperature is. Next slide, please. Before we get into our chat today, let me just talk a little bit about this resource that I know most of you know about, but maybe some don't. And that is the My NHPCO pages, which house all kinds of really helpful information for folks who are members of NHPCO. It's a collaboration of 15 discipline-specific professional communities. They host forums like this, post tons of great information. Next slide, please. We have monthly chats, library entries, there's a blog. One of the places that I think people forget to look on here are the library entries. There's so much good stuff there, whether it's a form that you don't want to recreate or a policy you want to rewrite or whatever it happens to be. Have a look in those library entries. There's always good stuff there. Next slide, please. And those of us on the Bereavement Steering Committee would love it if you wanted to reach out to us, if you have questions about membership, if you have topics you'd like us to discuss. This is especially important, and I'm going to bring this up again a little bit later. If you'd like to become a community committee member, or if you'd just like more information about how to stay connected to our professional community, please feel free to reach out to us. Next slide. Oh man, Richmond, Virginia, 94 degrees. And you probably have like 90% humidity, where on a good day, our humidity is like 5%. Before I get started, I want to thank some folks who helped me put this presentation together, or who allowed me to use older material. The Center for Prolonged Grief at Columbia University, the Hospice Foundation of America, a British researcher, Dr. Barney Dunn, my current employer, Reliance Hospice, for allowing me the space to do this today, and a previous employer, the University of California, for letting me use the research that I did there in my current work. Next slide, please. So today, what we want to do is talk a little bit about the current conversations and controversies around prolonged grief disorder. I'd like to review with you all some evidence-based information about PGD, and of course give you some basic resources for continued education in PGD. That's a typo, sorry. The other thing I want to talk a little bit about is something that I spend a lot of time talking about whenever I do webinars like this, and that is the importance of clinician researchers, people like us doing research. So I want to tell you a little bit about that toward the end of the presentation as well. Next slide. I know we already said this, but if you had a chance to test out your chat box, tell us who you are and where you're from. As I said, the temperature if you'd like, and be ready to use that box, because in a lot of places as we go through this presentation, I'm going to ask for your feedback or ask you to participate in a larger conversation. You can talk in those boxes whenever you want. You don't have to wait for me to finish talking. It's not like you're going to interrupt me. And I really welcome as much feedback as you're willing to give. Next slide, please. A question that I'd like us to run on as we go through this material, and just, write this down, think deeply about it if you want to. Why are there, or why do you hold strong feelings and beliefs about what grief is or isn't? And the reason I want to use this as a question to run on is it seems to be the sort of underlying stream of emotion that attaches itself to this conversation about what we really believe grief is or isn't, or where it comes from, or the best way to help people with it. Next slide, please. And I also want to do a little framing up front with a couple of definitions. Evidence-based practice is defined as the explicit and judicious use of the best available scientific evidence in professional decision-making. Evidence-informed practice combines the most relevant evidence available along with lived experience, client voice, and professional judgment. And finally, from the ADEC Code of Ethics, death education and grief counseling are based upon a thorough knowledge of valid death-related data, methodology, and theory, rather than stereotypes or untested hypotheses. Thus, the practice of death education and/or grief counseling requires knowledge of current thanatological literature. That hopefully will be the only slide that I actually read to you. Next slide. So over the last couple of months in the grief and bereavement business, we've had ourselves a little bit of controversy, a little bit of conflict. And that has revolved around the American Psychiatric Association's decision to add prolonged grief disorder to the DSM. And so that's kind of what drives our conversation today. There have been a lot of reactions to that. I found all of those reactions really, really interesting. I expect many of you have too. And so we're going to start out just talking about how this little brouhaha started. Next slide, please. Probably the leading article that got people talking, although there have been many articles about it, was this one in the New York Times. How long should it take to grieve? Psychiatry has come up with an answer. And of course, those of us in the business, all of you probably can recognize everything that's wrong with this headline and everything that's wrong with the little sentence that follows it. The real conversation about prolonged grief disorder really isn't about how long it should take to grieve. And it really isn't about the notion that psychiatry has come up with an answer, because they haven't. There's two other words in this sentence that jump out at me: controversial and new. And at least historically, PGD is not controversial, and it definitely is not new. So we're going to get into some of that as we go on. Next slide, please. Now, Psychology Today got this conversation a little bit more accurately, I think. The good, the bad, the irony. They talk about how prolonged grief disorder, some people think it pathologizes a normal human experience, but upon further examination, it's really not that simple. It is thought of as an overlap between trauma and depressive disorders, and it is correlated to high rates of physical comorbidities and mortality, as we're going to talk about more as we go on. Next slide, please. Some folks sort of got a little bit loud about their feelings around this. This particular author talks a lot about how this is really just an excuse to come up with a new drug and give people a psychiatric diagnosis and fill them full of pills. In this particular article, in these two paragraphs, the inaccuracies are pretty rampant. And so one of the things that I think we can do as professionals in the grief business is talk about what this really is, and talk about what it's not. Next slide, please. Some folks with very well-known names in our business even felt the need to step up and announce that grief is not a disorder. And let me just be clear when I say that I couldn't possibly agree more. And I think everybody on this call today probably agrees that grief is not a pathology and grief is not a disorder. I would argue that nobody is saying that it is. Next slide, please. Anthony Smith, in that same Psychology Today article, made a very good analogy. To put things into perspective, anxiety, depression, and insomnia are also normal human experiences, but no one's calling for their derecognition as potential disorders. And, uh, and I think that as we look at what the definition of prolonged grief disorder really is, and you start listening to some of, especially the descriptive words attached to it, you'll understand why this comparison is so apt. Next slide, please. And so let's just decenter the popular media. Let's put that conversation aside if we can. PGD isn't pathologizing grief. I would argue that nobody in our field is advocating that it is. PGD isn't anywhere near new. We've called it complicated grief, and we've been studying it intensely at least since the mid-1990s. The current evidence-based treatments do not include any sort of pharmacological intervention, although if you've got a comorbidity like anxiety or depression, that might be factored in. PGD does not place time constraints on grievers. The time constraint issue, as you'll hear me talk about, is really about assessing severity. And the longer someone experiences severe symptoms tends to help you define severity. It's been a part of the diagnostic manual in Europe since 2000. It isn't normal grief. PGD isn't normal grief. It is, however, an unfortunate name because it comes right out and says prolonged grief disorder. I would have preferred a name that didn't put grief and disorder in the same sentence. Some of the early research is telling us that it is a normal process that becomes stuck or derailed. Next slide, please. And so all of that said, I just want you to sort of go into this conversation with as open a mind as you can. And remember that opening question that we started with, and think a little bit about what you know and what you think you know. And then let's see where all this takes us. Next slide, please. So I want you to notice the sort of strong words that are used whenever we're talking about a definition of prolonged grief disorder. Distinct from depression, prolonged grief disorder is marked by a pervasive yearning for the deceased. Evidence suggests that about 1 in 10 bereaved people develop PGD. Some studies I've seen go even lower than that. In my own practice, I would suggest that I probably I see it less than that. Next slide, please. The work that Dr. Kathy Shearer has done at the Center for Prolonged Grief at Columbia University School of Social Work has really been very instrumental in helping us understand what PG is and some of the best ways to treat it. I think she's probably one of the leaders in this field right now. And her research has shown that it can certainly lead to significant problems if it persists without treatment, like substance abuse, like suicidal thinking, like sleep disturbances, etc. Next slide, please. The International Classification of Diseases has had this in their material one way or the other since 2009. And again, I'm not going to read all this to you. You can see it for yourselves. But notice the areas that I've made the print a little darker. And again, notice the strong words being used to describe this: a persistent and pervasive grief response, persistent preoccupation, intense emotional pain, persisted for an atypically long period of time, markedly exceeding expected social, cultural, or religious norms, a significant impairment. Only if functioning is maintained, it's only through significant additional effort. So all of these words designed to sort of make sure you get the idea that this is nowhere in the same zip code as an individual's normal grief experience. Next slide, please. Our own DSM-5-TR in 2022 that brought prolonged grief disorder out into the open end of the newspapers a little bit. Classifies it as a trauma and stressor related disorder. it adds that the bereavement should take place or should have been going on for a period of at least a year. And again, that's a way to assess severity. And there must be evidence for one of two grief responses occurring at least daily: intense yearning and longing, and preoccupation with thoughts or memories. Next slide, please. In addition to one of those, one of these following things has to be going on for the individual at least daily for the past month. Identity disruption, a marked sense of disbelief, avoidance of reminders, intense emotional pain, difficulty reintegrating, emotional numbness, a feeling that life is meaningless, or intense loneliness. At least daily for the past month, 3 of these. Next slide, please. Somebody just wrote, I like the term prolonged grief experience. Me too. What a great word. Somebody else wrote prolonged grief response. I love those. Keep that up. So getting back to the DSM-5, it continues to go on that these symptoms have to be clinically significant. Again, here are these severity words we keep seeing come up. And you have to be sure to distinguish it from other depressive disorders. Holly Purgerson, who's been a researcher and was one of the editors of the DSM-5-TR, talks about intense, persistent yearning for the deceased person is specifically a characteristic symptom of PGD, but it's typically not a symptom for depression or post-traumatic stress disorder. And those are the two things that this particular disorder or grief experience looks the most like. Next slide. Again, we talked about 7 to 10% of individuals bereaved will develop PGD. That can rise up if the cause of the loss was traumatic or violent. Although rise up to 30%, that's a number that I have not found strong research for. So I'm not going to claim 30%, but I can certainly see how it would rise up under the circumstances of a traumatic or violent loss. Some risk factors for PGD, and again, this is out of Columbia University, include 3 categories: person-related, relationship-related, and circumstance and content-related. So previous loss experience, prior mental health problems, insecure attachment styles. Related issues include the loss of a child or spouse or a close relationship, and of course circumstances, violent or traumatic death. I put in bold italic prior mental health problems, child or spouse, and violent or traumatic death because from my practice, those are the things that I have seen most frequently. And I really want to emphasize, and again, this is anecdotal and it's just from my practice, but I bet you all have seen it too, that prior mental health problems are a significant trigger for a more complicated grief process. Next slide, please. I talked a little bit about how professionals can tell these things apart, and this is a little bit of information about how licensed folks might make a differential diagnosis. Is it in fact hard to tell apart from clinical depression or PTSD? A lot of people would say no. In PGD, yearning longing is marked, where in depression it's rare. In PGD, the ability to feel pleasure is restricted, but it's still there, whereas in depression, the inability to do that tends to be more pervasive. In PTSD, the primary emotion, of course, is fear, whereas in PGD, it's a yearning or a longing. One of the things that's a significant symptom of post-traumatic stress disorder are nightmares, and that's rarely found in PGD. And another significant identifier of post-traumatic stress disorder is a person who describes reliving a memory as opposed to remembering it. Whereas remembering it is more along the lines of someone with prolonged grief disorder. Of course, comorbidities can be present. Depression can be present. PTSD can be present. And this is why it takes some care to make sure these things are sussed out. Next slide, please. Of course, the conversations we've been having the last couple of years around traumatic grief also bring up some some similarities to significant risk factors. I think this chart does a good job of pointing those out. Next slide, please. And I just put this in here because I thought it was a good graph to sort of show us the difference. The folks at Columbia University like to talk about this concept of integrated grief, which is a term I really like for what I would consider to be a normal grief process. Pangs of grief lessen over time. There's acceptance of the death. There's feelings of longing and yearning. Of course, you still have thoughts of your loved ones, but you're able to enjoy the company of others and you have moments of joy. Whereas when this process gets stuck, there are pangs of grief that are persistent and prolonged. There's difficulty accepting the finality of the death, intense yearning, preoccupation with thoughts of the person who died, avoiding situations and feeling numb. Next slide, please. So I'd like you to take a really deep breath and let it out, because I just threw a whole lot of information at you all at once. And I just want to tell you a little bit about my own experience of loss. And I know you can relate to it. So I'd like you to think perhaps about your own personal history of loss too. For me, my history of loss started on the playground when I was in the 4th grade because there was an accident that killed a student in my class. After that, and of course at that time, I don't know, we're talking about the early 70s, late 60s, early 70s. Everybody just wanted to avoid that it even happened. No one talked about it. Teachers didn't talk about it. Parents didn't talk about it. After that was my grandmother and then a beloved aunt. And as I got into my teens and early 20s, my brother died of AIDS and I lost a ton of friends to the AIDS epidemic. But later it was both my parents. And finally, in my loss history, I lost a spouse about 7 years ago. Now, in every case that I just mentioned to you, I could tell you stories that would make me cry. I could share memories that would make me laugh. All the time, I think of these people, usually annually around the days of the dead. I'll build an altar to honor them. But I'm able to function and I'm able to remember them with happy memories, and I'm able to continue on with the normal activities of life because I've integrated that grief. It's found a place in my life where it will always be. It never goes away. It just finds its own home. And I think that's true for all of us. A normal grief process turns into integrated grief, and it finds its own home somewhere in our heart, doesn't it? And I know you can relate to that. Next slide, please. So let's take a second, and I'm going to ask my colleagues, Karen and Joelle and Amy, who's joined us, if you all want to add anything to what I've said. If somebody wants to call out some questions, if you guys want to answer them, let's just take a minute and have a conversation.
I will say this has been such a great presentation already, and I'm just looking forward to everything that you have to share. And really, the only thing I would really add thus far is this is just a great reminder of how we are concerned about the future and what this all will mean. And I think that's really what it is that what this will all mean to our bereaved, to ourselves as professionals. Where is this all going? It's all new, and anything that is new opens up controversy, ethics, questions. So this information that you're providing is so relevant. Somebody did ask a question and they said, I have read that prolonged grief disorder is up to 15 to 18% with the additional stressors of COVID. Do you have any further information about this?
So I've read a lot of the same kind of stuff about, and in fact, I'm going to talk about that a little bit later on in the presentation, but I've read some similar things. I have not seen any of it attached to research yet. And this is one of those areas where I encourage those of you out in listener land to think about your own abilities as researchers, because this is the sort of stuff we need to find out. Is COVID a significant risk factor for prolonged grief disorder? My gut tells me yes, but I don't have research to support that yet.
Yeah, I totally agree. I think I've seen some research that has indicated that some of the early figures are looking like about 38% that they've seen in countries like China, and some early on here, just based on the nature of the loss, the acuteness of it, now
Sure.
the having the meaning and all of that. But you are absolutely right, Don. I haven't seen anything hardcore figures yet. And you really touched on actually the next question that came, and how might we have responsibility as bereavement professionals to teach this to our hospice staff and community?
Yeah, a great question. And I would argue that we do have that responsibility. We should be talking about it. I think I saw Joelle blink out of mute. Did you want to add something, Joelle?
I did, and it's along those same lines and based off of a comment that came in the chat from Lori about, I think the fact that PGD has gotten people talking about grief at all is great. And I couldn't agree more. A lot of our talks we comment on and start with, we recognize as grief professionals that often we are a death denying culture. We're pretty grief and pain avoidant. And there's often an absence of resources and understanding about the normal natural grief process. And so seeing all of this discourse within our media and having people explore it, talk about it, I think is great too. It elevates in our communities. Oh my gosh, I'm seen. Especially with the pandemic, I'm seen for the grief that I'm experiencing. There are some resources out there and people are exploring those. I think it also, in thinking about how we can educate our communities and educate our staff, many of our staff are likely coming to us and seeing us as experts or as resources for them, internal resources. We can take that opportunity, being mindful of what bandwidth we have, take that opportunity to infuse some of that content, whether it's during IDGs, or whether it's in onboarding new staff, or whether it's participating in all staff meetings in thoughtful ways, things like that, as well as maybe when we're working with folks, being mindful about our scope. And if we're referring people out into the community, when we're doing that, making touches with the community resources that may or may not be there, and checking to see you're listed as someone who is aware of and understands grief. Can we talk about that? And getting a sense of what is out there in our community. And if there's an absence of it, I see that in rural areas that have a lot of isolation already, they might not have a lot of resources, how to help support sharing information within our community about grief, as well as equipping ourselves. You know, how can we be more prepared if more folks are going to be accessing our resources? How can we be prepared to ensure that we're ready? We're ready for that. Karen, I think there are probably a lot more comments that came through that I haven't caught up to.
Thank you for all of that, Joelle. That I really think it was on point. Do you want to throw a couple more questions out there, Karen, and then we'll go on?
Yeah, you're generating some great discussion in the chat. A lot of people sharing how, of course, this prolonged grief disorder, potentially some of that related to the isolation that was experienced. Someone related that the multiple losses in a short time. And also asked, would you be able to contrast PGD and what has been described as chronic sorrow as it relates to ambiguous loss?
Yeah, so different terms, I would suggest different terms that are trying to point to the same thing. And probably that's one of the things that will come out of this a more intense conversation about prolonged grief disorder is definitions, right? You know, we'll all start using a familiar and similar vocabulary, perhaps, to describe the same thing as this whole conversation moves forward. The other thing I'm seeing in some of these questions that folks are putting out are research questions, you know, things that you could think of ways you yourself, right, in whatever hospice you're at right now, things that you could figure out a way to measure, that you could figure out a way to test and publish, or at least tell the rest of us what your results are. Those are so important, and I'm going to get to that later on in the presentation. Let's go ahead and go to the next slide for a bit, and then we'll come back to questions again. So lots of people in the comments, of course, talked about COVID-19. And is prolonged and or complicated grief more prevalent or likely? That's an important question that I think we all have a gut reaction to. And really, what are the limits of our resilience? Because that's what we're talking about, right? If we think about human loss, if we think about human grief, we almost always have to think about human resilience and how we've seen striking examples of it throughout our own lives, throughout our own human history. Does it have limits? What are the limits of it? And is something like COVID bringing us to the edge of what our limits are? Next slide. COVID, of course, has also been a part of this conversation about prolonged grief disorder. Articles like this in the Scientific American, COVID has put the world at risk of PGD. I don't know if that's true. I think that it might imply that it is, given all of the circumstances that have surrounded COVID and how each country has sort of had different ways that it's dealt with it. Some more heartbreaking, for lack of a better word, than others. And so it's a question that we really should be talking about. Next slide, please. Another example of the kinds of stuff that have been out in the popular press. This one calls mind to the fact that grief has been intensified, prolonged, and even denied because in some countries there's been so much politics attached to the pandemic. Next slide, please. This is a scene, that for me is heartbreaking. All of the Americans, now over 1 million, who have succumbed to COVID-19. But for somebody like me and for lots of people I know, this particular scene especially invokes for us another time. Next slide, please. Another time when we had another pandemic that was also driven by politics and also involved a lot of grief and a lot of loss. And it makes us wonder, are we experiencing those same things again? Is there any way this time around for us to do it better? Next slide, please. There we go. So I'd like to move over to the chat again. And people have alluded to this in the conversation so far today, but now I just want to name it directly. Go ahead and name all the ways that you think COVID-19 might challenge a normal grief process. And I'll leave it to Karen and or Joelle to read some of those out.
Thanks for that, Don. Yeah, as you noted, a couple folks were already commenting on that. And I even responded to someone too, but there was also another really interesting point made. So let's see, Michelle had noted the delay of funeral services was one that had an impact on grief because it was prolonging it in that people weren't able to complete that task of mourning. That was an unusual ritual they would have engaged in. And the idea that it was put off and put off, I think for many people, there was a sense of anticipation at some time in the near future, but unknown when, I'll be able to gather with people, I'll be able to have this formality. And we have so few rituals, or at least perceived rituals around grief. That was a big one for many.
I saw somebody that said, I thought this really jumped out to me. There's some great comments. Somebody said, it keeps going on. Julie Beck said it keeps going on and on and on.
Mm-hmm.
Yeah, that's pretty profound.
Yeah, it sure is. I mean, what a great way to put that. It really does. And I mean, every wave, you just take a deep breath and you're like, oh, I mean, what's next? What's going to happen now? And you think about it, personally for yourself as a grief professional, you think about your own family and your own friends, and you think about your workplace. You know, what's going to be on my desk for me when I come Monday? Is it going to be another 3 or 4 COVID admissions, or
Mhm.
our current staff or patients with COVID? It really does keep on going.
Yeah.
Mhm. Mhm. And when you
Yeah.
consider the bereaved who, many times in their grief, they are longing to return to some sense of normal, although they have to redefine what that looks like to them. I see when you're talking about that on and on and on and on. Through this epidemic or this pandemic, it's hard to find that new norm for themselves. And people have talked about the shaming those who haven't had the vaccine or haven't died or have died. Some of the shame, some of the separation, inability, as Joel talked about, the rituals, reduce access to support. Great comments.
Yeah, there's a flood of them coming in.
Mhm.
Folks talking about, to kind of piggyback on what Karen was pulling out, the suddenness as well. It can feel, and I think Michelle wrote the randomness, sometimes who does or who doesn't die. The inability of people to be present with one another, to say their goodbyes, or to see other people shortly after. Maybe also feeling like it might not be that other people are isolating from you, but that you also, maybe because of your own compromised health, are not able to connect with others out of fear. And fear is definitely a common theme in the pandemic. Fear for getting sick yourself or compromising someone's health whom you care for or live with. So lots of folks talking about isolation, stressors in their own lives, other layers of loss. Lots of things here.
So 2 things, I was just seeing a flash by on my screen. One that just touched my heart. Looks like Michelle wrote about the guilt that her husband feels about bringing home COVID over a year ago. That's just so personal and touching. Thank you, Michelle. The other thing that just I had to take a deep breath on, because I knew somebody was going to say it, is the grief that we all feel around mass shootings at the same time that the COVID is happening, and the effect that must have as a potential risk factor. I was a trauma chaplain for nearly 20 years, and in my career, I've had to respond to 2 mass shootings and schools. And in one of those cases, I had to tell the parents of a youngster that their child had been killed. And that was a long time ago, but that sort of stuff stays with you. Like my other grief, it's integrated, but it makes watching mass shootings, especially as they seem to increase, really, really hard to watch. And I know that among the 125 of you that are out there right now, you are all feeling that same thing. Next slide. So how about asking this question? Is there a way that hospice can help reduce the possibility of someone having an incidence of prolonged grief disorder? Are there tools in our toolbox that we can bring to the table to help prevent it? And again, this is a huge research question that somebody needs to work on, because we don't really know yet if there are ways that we can. But I bet, sort of from your own experience, from your gut, you're probably thinking, yes, there are. So let's do a case study, and then we'll give you guys a chance to comment about some possible ways that that we can make this experience less apt to turn into an episode of prolonged grief disorder. So our patient Robert is a 68-year-old male admitted with fever and acute respiratory distress. He has a history of COPD and diabetes. At admission, he's awake and alert, he's a full code, and he tests positive for COVID-19. By day 5, he's not responded to standard COVID-19 protocol, and his oxygen requirements have increased to 15 liters. If you don't know or have a clinical background, that's a lot. It's time for his family and him to discuss goals of care, because the next step would be intubation and a respirator. Robert refuses intubation, citing his already deteriorating quality of life before he came into the hospital. He requests that his status be changed to do not attempt resuscitation. His family agrees, and he's admitted to general inpatient hospice care in the hospital he's in with the hope of going home. Next slide. And so here are the challenges and the risks that are present in this particular case. It feels sudden and traumatic to the patient and family. The family is unable to visit. The wife has chronic health conditions. She does test negative for COVID-19 at this time. Adult children are scattered around the country. There's travel restrictions in place. Patient wanted to leave his grandchildren recorded messages before he dies. Patient wants to see his pets one last time. And of course, the hospital and the hospice's resources are stretched. Next slide, please. So, time for the comment box again. How can hospice mitigate these challenges? What can we do as hospice professionals to help this family and potentially reduce the risk that this situation brings of prolonged grief disorder? Ready, set, go in the chat box. And Karen and Joelle, jump in anytime you like.
Thanks for that, Dawn. I note not a specific response to that posed question, and I'm sure folks will start to share their thoughts on that. But there was a comment about, and I don't think that they're alone at all, from Brentney saying, to be honest, the elevation about COVID loss being somehow more important than other grief is frustrating. People have been dealing with horrible losses since the beginning of time, losing one's entire family in a car accident or war, or in a war, for example. And I really love the response that came from another community member, Kristen, saying, thanks for your honesty. I get concerned about that too. Related to this discussion, COVID-related deaths have more risk factors for prolonged grief disorder than other types of losses. But indeed, countless types of losses are immeasurably difficult. Sometimes even the things that we know are risk factors in a social context don't always equate to what the loss experience and grief presentation is for a particular individual. Something that I think we as a community are having discourse about in this moment because it is current in our context. But there isn't, none of our formulas indicate in the end, oh, this is the expected outcome for each person. Rather, just being thoughtful about what are all the things that might be a part of what could complicate the context of someone's grief, as well as then what about complicated grief disorder in our current context.
Yeah. I am seeing some stuff go by on the screen. Are you catching it, Karen?
Yes, we are catching it related to, I think that was a great comment, and we're seeing some comments related to the case discussion. I saw something that indicated the importance of early bereavement services. I think that is definitely a positive we have in hospice care, because we, of course, are going to assess bereavement risk at admission during the stay and then after the death. So assess early and bring in bereavement services even possibly before the death to begin some of that grief work, getting all the family and friends involved. Discuss what it takes to get home, not possible with that level of oxygen, and what it means if oxygen is lowered for family. Have all the family gather. So a lot of things with the family and all of that. So anything else I'm missing, Joelle?
I love the comment too, that hospice professionals have an opportunity to validate all losses, COVID related or not. Indeed, and to any person who does either respond to our outreach or who reaches out to us directly, we have what I think all of us on this call likely consider a privilege and an honor to be comfortable being the non-anxious adult in the room or on a call with someone who can hear what it is that they're sharing, normalize that, empathize with them, and offer them a relationship ongoing that holds space and bears witness to what unfolds for them, that their loss and their grief is something that we can hold with them. and support them in.
And it looks like, and this is just I think a sweet comment, soft and sweet, and gets to what you were talking about, Joelle, which I didn't have, I apologize, I didn't comment on, but I really enjoyed what you were talking about. This is Pamela who says, I don't think it's been elevated. And of course, she's talking about COVID. I don't think it's been elevated, but it's also very relevant and a current and additional potent stressor at over 1 million deaths in the nation. And yeah, that's true. I'm just scrolling down. Julie talks about risk to the wife of husband going home in a contagious state. Is it a risk she wants to take? Yeah, those are all really good responses. And I think you all demonstrate or have demonstrated in your answers that when we're brought in and given the opportunity to help people mitigate challenges, we do a pretty good job of it. And I think in months and years to come, when we do have the opportunity to do some good research around these subjects, I think the research will bear that out. Next slide, please. I said I'd mention a little bit about resources for education and recovery around prolonged grief disorder. And of course, the internet is full of them, but the ones that jump out at me are studies like the ones in the Journal of the American Medical Association that showed that regular old cognitive behavioral therapy outperformed counseling with medication in terms of helping people with PGD. There are several evidence-based treatments that have come out of Columbia University and Dr. Kathy Shear. And of course, research is ongoing and informs our practice even today. Robert Niemeyer's got a brand new book out, New Techniques of Grief Therapy. It's dated 2021, but I think it came out in January. If you haven't had the opportunity to look at that, it's wonderful. And it's very, very up to date from an evidence-based perspective. Next slide. I mentioned Dr. Shear's work at Columbia University, and her treatment model, progressive grief disorder therapy, is constructed around 7 core themes. And I'm going to get this wrong, but I think this is like a 14-week structured group and non-group therapy program. Some of you who have had training in it or are more familiar with it can maybe comment in the box. But the core themes that they use in that program are understanding and accepting grief, managing emotional pain and monitoring symptoms, thinking about the future, strengthening ongoing relationships, telling the story of the death, learning to live with reminders and connecting to memories. And if you look at each one of these individually, you'll see reflections, I think, of whatever current model you use to help people work through their grief. I think it's a really good sort of collection of methods that we've been using to help people for a long, long time. Next slide. So I promised that I was going to talk a little bit about research, and this is a comic that I just ran into. We believe this resolves all remaining questions. On this topic, no further research is needed. Well, nothing could be further from the truth. And those of you who have been in webinars of mine in the past, the last couple of slides I'm going to show you are going to be a little bit familiar. Next slide, please. I see that there are 126 people on this webinar right now. Every one of you should think about becoming a clinician researcher. It's not anywhere near as hard as you think. And there are easy questions and hard questions that we can do things like qualitative research through interviews, quantitative research through surveys. There are questions that we can help answer. I just think, for example, of the EGSS database and all of the research questions that could potentially be answered just with that. So these resources are available, and I really want to encourage you to get excited about using them. Next slide, please. If you do want to think about doing research, some ideas, Google Scholar's your friend, both for research and ideas. Some of us are scared off by numbers or percentages, or we think we just don't understands statistics, for example, enough to do real research, but everybody, every organization has somebody that does understand that stuff. And so all you need to do is find out who they are. You want to pick your question carefully because you really want to ask yourself if you want to know the answer. Almost all research is based on copying someone else's work, either for format or for ideas. And you certainly don't need an advanced degree to do research. Just ask Isabel Myers and Catherine Briggs, who all by themselves took the work of Carl Jung and developed the Myers-Briggs personality indicator. You can do this with colleagues and be co-authors together. They could be colleagues in your own hospice or colleagues here in this room right now, or other folks you meet at conferences. Often people get hung up with the idea of an institutional review board or informed consent when you're doing research. It's way easier than you think it is. And finally, professional journals are your friends. There's a number of journals out there that will print studies and research having to do with grief, bereavement, loss, and death. Reaching out to them and asking for help early in your quest to answer a particular research question will lend you more help than you can imagine. Next slide. And so we've talked about questions today in our time together that have brought us or reminded us of some questions that need to be studied. And there are certainly questions not relevant to what we've talked about today, but there's so many things out there that we should look at. How should hospice screen for PGD? Do we know what PGD triggers might be? Do we know if a positive hospice experience might prevent it? And if so, how? We definitely need more studies on grief and bereavement in very specific ethnicities, cultures, and communities. We're so lacking in that area. We need more literature review studies. What do we actually know? What actually is evidence basis right now in 2022 in our profession? We need case studies that share current best practices. Do our current, this is a Joint Commission or inspection visit question all the time. Do our current bereavement practices reflect the needs of the bereaved? What research do we have to show that they do? Are we more at risk of PGD in a pandemic? And even if you have topics that you're not really sure what to do with this, bring them to us on the Bereavement Steering Committee, and we'll help you work through them. We'll help you develop a seminar just like this one that you can give, where you can talk about these things with your colleagues all around the country. We really want to be a help and a resource to you in that regard. Next slide, please. It seems to me that, and I said this earlier, at the end of the day, so much of what we do in our work around grief and bereavement and understanding what blockages might be to that normal process that lead to prolonged grief disorder. How much does resilience swim around in this water with us? And how much resilience do we really have for loss? And of course, I don't know the answer to that. I don't think any of us knows the answer to that. But I think I'd like to end our conversation today just by reminding us of the resilience that we have as professionals in this field, by reminding us to look at and celebrate the resilience of our clients, and even at risk of all the pain that already lives there, to look at the resilience of societies that have figured out how to get through times like this. I'm going to open it up to more questions, but I want to end with a poem about resilience. It's one of my favorites. It's by Mary Oliver, and it's called Wild Geese. You do not have to be good. You do not have to walk on your knees for 100 miles through the desert repenting. You only have to let the soft animal of your body love what it loves. Tell me about despair, yours, and I will tell you mine. Meanwhile, the world goes on. Meanwhile, the sun and the clear pebbles of the rain are moving across the landscapes, over the prairies and the deep trees, the mountains and the rivers. Meanwhile, the wild geese, high in the clean blue air, are heading home again. Whoever you are, no matter how lonely, the world offers itself to your imagination, calls to you like the wild geese, harsh and exciting, over and over, announcing your place in the family of things. Next slide. I want to thank all of you for being with us today. I want to thank Joelle and Karen, and we have about 4 minutes left to answer any questions you might have. So let me have them.
There are a couple that have come through our chat and a few comments too. The ones that were in the Q&A, there were some about, I have a concern that various forms of privilege, such as racial and socioeconomic, are protective factors, while marginalization and oppression of other groups may contribute to greater risk for and or overdiagnosis of PGD, perhaps because of differing cultural views on the definition of intensity. Any thoughts on that?
Well, for me, dead on. And the other thing I would add is this is why whenever I talk about research, I talk about our field has done very little, not nearly enough on how specific ethnicities, communities deal with grief and bereavement. I know that we talk a lot about cultural differences. I just don't think we do it nearly enough.
Thank you, Don. There was also another comment about sharing the slides, and that's certainly fine. All of this information will be saved in our library for folks. And a comment from Pamela about recognizing and acknowledging or accepting the powerlessness towards death is the first step towards healing it. And David commented after that, the dance of recognizing the limits of what we can and can't do. And that seems like a really close akin statement to what you were sharing about resilience. And I think a lot of the research and the training protocols around, such as with the Center for Complicated Grief, with Dr. Kathy Shearer and others, speak to the importance, even more so now in the field of bereavement, infusing content and focus around self-compassion. Self-compassion for ourselves and helping to develop and support that within our clients, which makes a lot of sense. In our culture, we tend to be pretty hard on ourselves and evaluate how we're doing with grief. If we're feeling or experiencing grief at all, that's somehow not a good thing, and that's bad. But yet self-compassion is one way that we can certainly build up our resilience as practitioners as well as within our client base.
So I'm just gonna, it's 11:59 and I'm just gonna end our time together again by thanking Don and Karen and Joelle and everyone who attended today. And I just want to end on this comment box from Margaret, who says, I hope you each find a way to nurture yourself as you hold sacred space, listening and supporting your clients and staff. Blessings to all. And I concur, and I hope everybody has a wonderful day. Thank you for coming.
Well, that concludes today's chat. Thank you very much, Don, Joelle, Karen, and the Mind PCO bereavement professional community for producing this important chat. As a friendly reminder, today's chat recording will be made available in the Mind PCO bereavement professional community library in a few days alongside these slides. Please join us next month for our next chat, July 6th at 2 p.m. Eastern Time. Also, as mentioned before, if you want to join the Mind PCO Bereavement Professional Community Steering Committee, you can go to the following link I'm about to post in the chat box. And this is actually at the top of the bereavement professional community. Go to the following link and then click on the Learn More, the green Learn More button to learn more about how to apply for the steering committee. And then lastly, when I end this chat, there will be a link to go to a post-chat survey that'll pop up on your screen. And this will help us, find out what you felt about the chat and for any suggestions you may have to help us plan for future community chats. Again, please, everyone, thank you for being with us today, and please take care of yourselves and have a great day.